That is, there are many types of diseases which are included in cardiomyopathy, and all these diseases are associated with mechanical and or electrical dysfunction. So it might be totally mechanical or it might be electrical dysfunction, and that exhibits inappropriate ventricular hypertrophy or dilatation. And these are due to a variety of causes which may be inherited or which may be in situ. So these are a heterogeneous group of diseases, first thing. Secondly, they cause mechanical or electrical dysfunction. And thirdly, they are associated with ventricular dilatation and or hypertrophy. So these are the three factors which are present in cardiomyopathy. And they may be, as in endocarditis, they may be a part of the generalized disease system or a part of a heart disease itself. Now, classification is according to the etiology. It is primary, that is principally confined to the myocardium itself. On secondary, then it is a presenting as cardiac manifestation of a systemic disorder. Then second classification is according to the anatomic and functional abnormalities, and usually we classify myocarditis according to the functional abnormalities. So according to this, it is divided into three varieties: dilated cardiomyopathy, which is the commonest variant, accounting for 90% of cases. Second is hypertrophic cardiomyopathy, and third is the restrictive one, which is the least common. So there are three types: dilated, which is the most common, then hypertrophic, and restrictive, which is the least common. Now the cause can be specifically identified, that what was the cause, or it can be idiopathic. Now we'll study in detail each of these cardiomyopathy. In dilated cardiomyopathy, there is progressive cardiac dilatation and there is systolic dysfunction, usually with concomitant hypertrophy of the ventricles. So there is cardiac dilatation. When there is dilatation, there will be abnormality in the systole, that is, it won't be able to contract normally, and because there will be volume overload, there is hypertrophy of the ventricles. So what is the pathogenesis? How does it develop? Usually when it is diagnosed, it has progressed to the end stage of the disease and the heart is dilated, poorly contractile. Yeah, come in the front row, please. And usually a specific etiology cannot be ascertained. However, there are various factors which have been considered. One of this is genetic, because it is familial in 30 to 50% of cases, and it is caused by mutations present in more than 20 genes. And what are these genes? These are usually encoding for the cytoskeletal proteins. And what are these cytoskeletal proteins? These are the TTN with gene that encodes for titin, and these accounts for 20% of cases of dilated cardiomyopathies. That there are more than 20 genes. However, titin, the gene TTN, a gene that encodes titin, is the most important one, accounting for 20% of cases of dilated cardiomyopathy. It is usually autosomal dominant and is predominantly X-linked, and the autosomal recessive and mitochondrial inheritance is less common. So mostly it is autosomal dominant. Then the second cause which is postulated is myocarditis. So the footprints of viruses like Coxsackie virus B and enteroviruses can occasionally be detected in myocardium from the late stage. So what we get? We can get antigens in either in the heart muscle, or we can detect the antigens or the antibodies to it in the blood. So the biopsies have documented it is the infectious myocarditis which then progresses to the dilated cardiomyopathy. So there may be viral transcripts or elevated antiviral antibodies. So we can detect either by the biopsy and secondly by the antiviral antibodies in the blood, which says that it is due to post-myocarditis. So first is genetic, second is post-viral myocarditis. Thirdly, alcohol and other toxins. And alcohol abuse is strongly associated with dilated cardiomyopathy because alcohol and its metabolites, they have a direct toxic effect on myocardium. And the chronic alcohol is also associated with a thiamine deficiency, which causes beriberi heart disease, which very much resembles the dilated cardiomyopathy. It can also be related to the drug adriamycin. Then it is also known as the side effect of childbirth. In this, the etiology is multifactorial. This is associated with pregnancy-associated hypertension, volume overload, nutritional deficiency, metabolic derangement, especially in ladies who develop gestational diabetes, and if cleavage products of prolactin, which are usually raised in late stages of pregnancy, if they rises disproportionately, they may cause dilated cardiomyopathy. If there is a defect, primary defect in microvascular angiogenic imbalance, it leads to functional ischemic injury leading to cardiomyopathy. But however, half of these patients recover spontaneously. Half of the patients who develop cardiomyopathy after childbirth recovers. Then the fourth cause which is stated is the iron overload. It's in the front rows, please. And it can result from hemochromatosis or from multiple transfusions which are needed due to any cause. And usually it is due to interference with the metal-dependent enzymes, or it may be due to the injury caused by iron, so resulting in increased reactive oxygen species, which lead to a toxic injury on the myocardial cells. So it may be either due to the activation of the enzymes, or it may be due to the direct toxic effect of the iron on the myocardial cells because of the development of reactive oxygen species. Then another cause is the supraphysiologic stress. That is, we are putting more stress on the heart. So this can be due to persistent tachycardia due to any cause, hyperthyroidism, and if during development in fetus of insulin-dependent diabetic mothers, and if there are excess catecholamines, which may be due to tumor pheochromocytoma. So in this, the mechanism is direct myocytic toxicity or due to focal vasoconstriction. Focal vasoconstriction will lead to ischemic injury, and which will lead to cardiomyopathy. Now we have seen the causes. Now we come to the morphology. So what we see in the heart itself. So characteristically, the heart is enlarged, it is flabby, and there are dilatation of all the four chambers, and there is wall thickening. So the ventricle thickness may be of both the right and left may be same, the ventricular thickness, and because it is dilated and the flow of the heart is not that great, so mural thrombi will develop in the chambers, and any causes valvular and vascular lesions. I mean, to say that it is a primary cardiomyopathy, all the secondary causes that causes the dilatation of heart should be absent in the morphology when we label it as dilated cardiomyopathy primary. Okay, because there may be some valvular like mitral regurgitation is there, so that should be absent. You can see a dilated ventricle and a mural thrombus inside the ventricle, and here you can see that the muscle cells, they are very apart, and you can see collagen, the blue colored collagen in between the muscles. Now the characteristic histological abnormalities, they are very non-specific and they do not typically point to a etiologic entity. Only exception is when it is due to iron overload, because in this we can see intramyocardial hemosiderin, and this can be demonstrated by Prussian blue. In Prussian blue, the iron stains blue, and most myocytes exhibit hypertrophy with enlarged nuclei. However, many myocytes may be attenuated, stretched, and irregular. So you see here in this, there is both hypertrophy and dilatation of the heart. There is also interstitial and endocardial fibrosis. Now this fibrosis reflects that there has been a previous ischemic necrosis which has been caused by hypoperfusion. So all these are non-specific. So it includes that myocytes are enlarged or they may be attenuated. So some myocytes may be enlarged, some may be attenuated. There may be fibrosis, and this fibrosis usually reflects the ischemic necrosis that the heart has suffered. And if it is due to iron overload, you can see increased iron, and this can also be demonstrated by iron stain, which is the iron stain Prussian blue, which colors the iron stores as blue color. Now clinical features, it is mostly diagnosed between the ages of 20 to 50 years and usually presents with a progressive CHF, congestive heart failure. So what are the symptoms of congestive heart failure? These are the dyspnea, easy fatigability, and poor exertional capacity. That is, the patient cannot exert himself, he cannot do much physical labor. And the patient can very easily slip from a compensated stage to a decompensated stage. So the heart failure stages have been told to you in the heart failure, I told you. So the fundamental defect in this is inefficient contraction. The heart cannot contract properly. So when it cannot contract properly, the ejection fraction is less than 25%. Normal is 50 to 65%. What is ejection fraction? The amount of blood that is ejected from the ventricles proportion to the blood that was present before systole. So what amount of blood is ejected during systole? So normally it is more than 50 to 65%. In this it comes down to less than 25%. So most of the blood remains in the ventricle itself, in the heart itself, causing its dilatation. So secondary mitral regurgitation and abnormal cardiac rhythms, they are common, as also embolism can occur from the mural thrombi which develops due to stagnation of the blood in the ventricles. So half of the patients, they die within 2 years, and only 25% survive longer than 5 years. And death, what is the common cause? First is the progressive cardiac failure, and secondly arrhythmias. Why arrhythmias? Because as the heart dilates, I had shown you in the diagram, the distance between the myocyte cell increases. So the ionic coupling that occurs from one cell to another is disturbed. So the ions cannot travel from one cell to another, causing arrhythmias. And cardiac transplantation is the only definite treatment that is possible. And nowadays other treatments are being considered, like implantation of long-term ventricular assist devices, but in this it can cause regression of the cardiac dysfunction, so they are not very effective, and cardiac transplantation is the only treatment of choice. The second is the hypertrophic cardiomyopathy. So in this there is myocardial hypertrophy, and in this there is defective diastolic filling. That is, the heart is not filled properly. In dilated, it could not contract properly, and in hypertrophic, it is not filled properly. And in third of the cases, it's almost 9:30 now. In third of the cases, this is due to ventricular outflow obstruction. No, you can go. In this, the heart is thick-walled, heavy, and hypercontractile. Now this has to be contrasted with the flabby and poorly contractile heart in the dilated cardiomyopathy. In this, the systolic function is preserved, but myocardium does not relax during diastole, and it needs to be distinguished clinically from the disorders which cause ventricular stiffness. For example, amyloid deposition in the heart. It also causes heart stiffness and ventricular hypertrophy because of aortic stenosis and hypertension. So these are the secondary causes which cause ventricular hypertrophy, and they have to be distinguished from idiopathic hypertrophic cardiomyopathy. Now, most of these cases are caused by the missense mutations in genes encoding the proteins that form the contractile apparatus. It is also autosomal dominant, and almost 400 causative mutations have been identified. However, the most important is the disorder of sarcomeric proteins. And of the sarcomeric proteins also, the important one is the beta myosin heavy chain, which is frequently affected. So most common protein is the beta myosin heavy chain, and the second is the myosin binding protein C and troponin T. And mutations in these three genes account for 70 to 80% cases of hypertrophic cardiomyopathies. So the most important are beta myosin heavy chain, myosin binding protein C, and troponin T. So these account for almost 80% cases of the hypertrophic cardiomyopathy. Now all those mutations, they have one feature common, and these are that they all affect the sarcomeric proteins, whichever protein it may be, and they increase the myofilament activation. That is, they activate it so that it is almost in the contractile state. It does not relax. Now this is marked by massive myocardial hypertrophy without ventricular dilatation, and there is disproportionate thickening of the ventricular septum relative to the ventricular free wall. That is, there is more hypertrophy of the septal wall and less hypertrophy of the free wall of the ventricle. And usually in secondary causes of ventricular hypertrophy, it is opposite. That is, usually the free wall of the ventricle is more hypertrophied than the septal wall. And therefore, this is also known as the asymmetric septal hypertrophy. And in 10% of cases, concentric hypertrophy, that all the walls are similarly involved, can be seen. However, in 90% cases, you will see the asymmetric septal hypertrophy. And on longitudinal section, so it will give rise to a round to ovoid shape, banana-like configuration. Now there is an endocardial plaque in the left ventricular outflow tract and thickening of the anterior mitral leaflet. These changes correlate with the functional left ventricular outflow tract obstruction. Because the septal wall is thickened, there is outflow obstruction to the blood, and this outflow obstruction will cause plaque in the left ventricular outflow tract, and it will also cause anterior mitral, the leaflet will be damaged. The histologic features that are present are the myocyte hypertrophy, haphazard myocyte, that is, the myofibers become haphazardly arranged, known as the disarray of the myofibers. There will be interstitial fibrosis. Here you can see that is asymmetrical septal hypertrophy giving a banana-shaped appearance of the ventricular lumen, and you can see the myocytes are enlarged, the nuclei are very large, and in between you can see the light-colored fibrosis of the muscles, in between the muscles. Now, clinical features, they can present at any age, but usually it presents during the post-pubertal growth spurt, and it is characterized by a massively hypertrophied left ventricle that paradoxically provides a markedly reduced stroke volume. That is, ventricle is hypertrophied, but because it does not fill properly during diastole, the stroke volume, that is the cardiac output that it produces, is very less. So it is paradoxical that it is hypertrophied, it is contracting very forcefully, yet the stroke volume is very less. This is because of the impaired diastolic filling and because the muscle is also very hypertrophied. So the capacity of the lumen of the ventricle is decreased. So the amount of blood that can come in the lumen is decreased. Okay, understood? So there is reduced cardiac output, and this reduced cardiac output causes a secondary increase in the pulmonary venous pressure. When pulmonary venous pressure increases, it will cause exertional dyspnea and a harsh systolic ejection murmur. So the cases of dilated cardiomyopathy, they come with features of congestive heart failure, and cases of hypertrophic cardiomyopathy will come with exertion, that is the pulmonary symptoms, exertional dyspnea and a harsh systolic ejection murmur. And because there is massive hypertrophy and also left ventricular pressure is high and it does not relax during diastole. As you remember, most of the supply to the cardiac muscles is during diastole by the coronary arteries, and when it is not relaxing, the blood supply to the coronary arteries is impaired. When blood supply to the coronary arteries is impaired, it will result in ischemic necrosis, resulting into ischemic heart disease. Okay? So the major clinical problems encountered in the hypertrophic cardiomyopathy are atrial and ventricular fibrillations with mural thrombus formation, infective endocarditis of the mitral valve, because in this, as I said, mitral valve becomes deformed, and endocarditis frequently involves the deformed valves. Then it will cause heart failure and sudden death. So what is the treatment? Treatment is promoting ventricular relaxation. This can be done by partial surgical excision, or there may be controlled alcohol-induced infarction of the septal muscles. So it will relieve the outflow tract obstruction. So basically you are relaxing the muscle either by surgical excision or by a alcohol-induced infarction of the septal muscles. Now, the hypertrophic cardiac muscle is a very important cause of sudden cardiac death, and in almost 1/3 of the cases under the age of 35, sudden cardiac death is due to the hypertrophic cardiomyopathy. So it is very important if it can be diagnosed earlier and the patient treated, because the young adults can be